Next, we have the keynote address by Dr. Sandra Ganesh ma'am, Senior Consultant, Pediatric Ophthalmology and Strabismus, Head of the Visual Rehabilitation Center, Aravind Eye Hospital, Coimbatore. She'll be speaking on how to set up a myopia clinic in your routine clinic practice.
Thank you, Tanu, for the invitation, and I'm very happy to be here. So, this is the last talk of today's session, and I'll be talking about our experience of establishing a myopia control clinic. So, definitely we'll be touching upon few of these aspects here. Public health importance, as everybody has highlighted. Implementing into clinical practice, everybody has almost done it now, because looking at the load of myopia, and we have been looking at various guidelines for atropine and glasses and all. It's all evidence based practice, and choosing the strategy for each patient is definitely important, because it's a case by case scenario. General guidelines are definitely there. Compliance is something to be stressed, whether you talk about atropine or glasses, mainly the lifestyle modifications, because that is not done, then it's not going to improve. So, you need a lot of discussion with the parents and the patient, and also something on marketing the control of myopia. So, this is just one simple example of one day in Myopia Clinic in 2024. I had made this slide. So, that particular day we had seen 67 patients in our Myopia Clinic, where 32 of them had brought single vision glasses newly, 8 of them were on review, and 10 of them bought myopia control glasses new. We have not yet started contact lens options or orthokeratology in our clinic, and low dose atropine review was 4. So, as it is now, even the most common management is the single vision glasses for myopia. So, that needs to be stressed, that we cannot replace everything with the myopia control strategies. Most of the time, so we need to look at, so why was it not given, whether maybe the indication is not there, maybe they are coming the first time. So, without documented progression, we will never start on a myopia control strategy. Because you start unnecessarily, then you will be looking at rebound and so many other things, the cost effectiveness, whether it is really necessary or not. But was this the beginning? Like even now we are seeing even more than that in the Myopia Clinic. So, the beginning was definitely compared to pre and post COVID numbers, we saw the need for setting up Myopia Clinic as a separate entity even within our pediatric clinics, and I think that's the same with all the people who have talked today and even among the audience. So, what we saw was there was definitely a higher number of new myopes being diagnosed post COVID. This was not just a lag in the people coming to the hospital, it was a sustained increase that was being seen. So, and also we know that it continues to progress, and in India we are seeing that many of them are continuing to progress even beyond the age of stabilization, that we say 18 or 20. Even adult myopia is a thing where we are the thing about how to control adult progressive myopia is still not very well understood, but we know that with every diopter of myopia increase, there is going to be myopic maculopathy, glaucoma, PSCC, RD. Especially we are talking about high myopia. Anything more than -6 or more than 26 millimeters will increase the risk of any of these things. That is why the axial length is important, because there may be the size of the eyeball is not the same. There may be that there's something called axial length and keratometry, they compensate each other. So, you can have an eyeball with just -1, 1.5 diopter myopia, but axial length will be nearing 25, but their K reading will be flat. But since the axial length is the most important predictor for myopia progression, myopia complications and maculopathy and other things, so it is important to document. And also we are going to improve the quality of life of the child, definitely reduce the complications, and parents are definitely eager to invest in treatments that protects the child's future. So, it depends upon the way they are explained, and so that comes a question of chair time. So, how much time? It may not be only the consultant's time, it can be even the counselor who is being trained in that manner to sit and talk to the family for some time. It definitely creates an exciting and meaningful career. So, I think this post-lunch session with a full hall, I think it definitely mandates more discussion. So initially we were thinking about how to introduce and the DIMS had just come into the market, though it was not available in India so freely. So we were attending some meetings abroad and we came to know about these glasses, but at that point it was like during COVID we couldn't introduce. But we were having some discussion, and then we started with the Zeiss team with the Myovision. Was the thing that we started initially. But as we all know, the response was not very good. So after some time, it was totally replaced with Myocare, and Hoya came in between. So the first Myopia Clinic was established in June 22 in Aravind, Coimbatore, and at that point, it was the first of its kind center in Coimbatore. And so when we set it up, there were no clear guidelines that at that point 21-22. So we had to update our knowledge, survey the patient base. So once we set a clinic, how many patients are going to come, train your staff, set up the workflow, invest in some equipment, study the results and ensure compliance. So I think this will be the common steps for everyone. So updating the knowledge is definitely, there was a lot of discussions during COVID, the webinars had come, and there were a lot of discussions on this regard, and a lot of publications were coming in slowly. So we need to attend like evidence-based research and meetings, non-commercial websites, and don't go by what the company people are going to come and say, because each one will say theirs is the best, and we have to have our own way of analyzing the results, and then we convince ourselves, then we can convince the parent and the family. So around 10 to 15% of the number of clinic patients who are walking into any practice, whether it is high volume or less, even if you say 10 patients, 1 or 2 are going to be myopic. If you see 100 patients, some 10 are going to be myopic. So that is the percentage, and pre-myopia they have already defined. So the initial days it was going very slow. We are thinking of setting, we have introduced the glasses, and the number was very less. We had educated our department. We have 6 or AS consultants, and we have a couple of fellows. We told everyone, okay, once you see myopia patient, please advise the lenses. Nobody advised, because it was so new, it was so different, everybody was afraid, they didn't know what it is. Like suddenly you are telling to advise something, they will see, as you can see, it is 2, 4, I think these were the ones which I have given, the others were 0. Okay, so then what to do? Okay, then we have to show them one patient, we have prescribed the glass, come after 1 week, they are happy with the glass, at least their parents are not, it is visually the same, because nobody knows anything about these glasses at that point of time. And then we thought, okay, then I thought, okay, I will go and sit inside myopia. I am a passionate strabismus person. I had to give up strabismus for 2 years almost, go and sit in the myopia clinic and set up the protocol for everyone to get confidence to start myopia management. Then I had to train the refraction person, because we had to do the MEM, do the binocular vision assessment, not all the steps, a few steps which are mandatory for myopia control, and train the manager, train them for counseling, set up the steps, and then we created the myopia inside the EMR, because once the patients are registered into EMR, then we told the inclusion criteria to the refraction. The first step is they go to refraction. So ours is high volume center. So once the refraction people know the criteria, then we want ages from 6 to 14 only initially, and we want the myopia who are not like pathological myopia, who are not keratoconus patients. So all these criteria we told them, and so they are directly from the pediatric refraction they were put into myopia. So at least the patients were named as myopia clinic patient. From then we started plant the seed early with the parents. So when they will be sitting for other investigation, somebody will talk to the parent, and then so whom to treat. 6 to 14 we started as active control, simple myopia or not to a pure astigmatism. Cylinder should be stable. If there is any doubt, do a topography, and definitely there is insufficient, there is no evidence to treat pathological myopia. We see many patients coming with the just plain astigmatism with atropine. So now we say we are going to treat pre-myopia, but have you the evidence? Has that patient shown an increase in axial length at least? How do you know that that is a pre-myope? So many patients may be just remaining as just a cylinder, they will not progress. So unless you are having a family history or you are documenting that astigmatism patient is having increase in axial length, I would not think just because it is there we should not prescribe. Okay, then myopia with glaucoma, prematurity, yeah, you can, provided there are no other issues. With a cylinder, like there will be 0.25 sphere with -4 cylinder, that may not be a good candidate for myopia management spectacles. Definite indication, young age of onset. One of the most dangerous myopes are young age of onset. You have a -2 at the age of 6. Take that family very seriously, because they are going to look at the things that are going to be most meaningful if you are going to not let that myopia progress beyond -4 or -5. So you can avoid all the complications. Strong family history, both parents, one of them post LASIK, and all that you have to take into consideration. Then we developed the checklist, like in the time, so our clinic was building up and we didn't have time to ask, because once you start question about family history, they will all start talking, parents, and they will talk for half an hour, like they are not listening. I tell them not to watch the TV, so they start in that line, then our clinic will not finish. So we started giving the checklist, okay, you fill up all these things and then we will see. So we gave the thing, and then we started to stratify the risk for progression, like we just made a low, medium. See, you can have it in a better way, but our EMR is not geared for research. It is, I think in most of the clinics is like that. So if I going to ask like AI related things, they are not going to give it. So we made a simple risk stratification for progression and just put a number of points, so that because clinic is having more than 10 or 12 doctors, everybody should be in the same page. Otherwise patient will get confused. The equipment needs are, I would say having a non-contact axial length is mandatory for managing myopia, except like, okay, some private practitioners, maybe it may not be there, but if it is there, then if it is in the vicinity, definitely use it. If you are in a tertiary eye care or any institute where they are using a biometer for axial length in cataract clinics, you can use the same thing for measuring for your clinics also. It is definitely a specialty service, and these are the tests that we do. The binocular, now we have simplified this, only 4 out of all this is completely required. And this is the, then we had set up that history inside the EMR, like now it is coming within the EMR, all the history, because so many number of pages are getting lost, and in the future if we want to do any study, we can get it as a printout. Then while they wait, all the counseling, document the progression, test roll of axial length, as we have already said, because it will give you 2 or 3 more parameters by which you can judge. Benchmark the efficacy of any treatment is, like if between the intervention group of 0.25 diopter per year, they have regarded as clinically significant. Then treatment objective is to slow the rate. See, definitely it's not going to stop the eyeball from growing. So that is what you need to impress upon the parents, because it is going to make it the same as symmetropic progression. There definitely is going to be a power change, because they are investing so much doesn't mean that they are going to maintain the same glass for 3 or 4 years. That is impossible. Impact of environment is already said. I think these things we can leave it. The target progression we have kept as for the younger age group less than 0.5 diopter per year, and in the older age group less than 0.3 or 0.25 per year is what is the target. Similarly for the axial length also. And then we made a new workflow. So this is how the patient flows through: refraction, A scan, binocular vision, then the doctor evaluation. Then for review patient, we may not dilate, like if demand every 6 months, if it's high myopic, okay, yeah. Otherwise, if there is no power change, we may not dilate also. And this is how the refraction, the workflow. So with all these, we were seeing an increase in the number of patients, and the patients and other doctors also got confidence to prescribe and follow the myopia management. Now I think it is okay. It has been 5 years now. I think so many forums have talked about the same thing, and I think even the junior most fellow also is quite confident to prescribe myopia management. So, and then you need to have some coordinator if you are looking at large number of patients, because it needs a lot of hand holding. especially with regard to some lens orders and modifications. Sometimes they did not get it very soon, all those things. And then we did a lot of research activities also with people visiting our clinics, and we had a lot of learning, especially like Dr. Padmaja from Zeiss group. They were very supportive in the initial. And we also set up myopia clinics in other, like first it was Coimbatore, then went to Madurai, then Chennai, then other Aravinds, we have replicated the same, and also in some of the other hospitals who requested, we have done the same. And a lot of awareness activities, even last week was the awareness activities carried out, and academically we had a lot of
So sorry,
inputs.
ma'am.
Yeah,
positive.
thank you. So that's it.